now that institutions have had exposure to AI over a certain period of time, does it change the way that we as radiologists have operated? Does it change the way that I dictate? Does it change the way that we teach our residents? How do we teach our residents to actually leverage these technologies in ways that we as the teachers haven't really experienced before? So some of my research is starting to lean that way going forward. And I think those are really exciting questions.
Welcome to RadCentral, a radiology podcast produced by Excalibur Healthcare. I'm Kiana.
I'm Betsy.
And today we have a wonderful guest speaker with us, Dr. Melissa Davis.
She is an associate professor of radiology and biomedical imaging at Yale School of Medicine. She also serves as the vice chair for imaging informatics in the Department of Radiology and Biomedical Imaging. Welcome, Dr. Davis.
Well, thank you. I really appreciate the invite.
Absolutely. So I kind of just wanted to start off pretty strong. Are you able to share with our audience how you dove into the radiology background and how you arrived to it as your specialty?
I think, I had no idea what radiology was when I entered medical school. So it was more of like an exploration for me. But I really enjoyed my anatomy class, and we had a radiologist speak at one of our anatomy sessions, and I was able to connect with them after that, and really just fell in love with the idea of being a diagnostician, being someone who sees pathology potentially first and can help guide management, being someone who could potentially do procedures on a patient that are minimally invasive, but have a big impact. And so those are the things that drove me to radiology and why I fell in love with it in the first place. Currently, I am a neuroradiologist as well as an emergency radiologist. And I feel like I kind of fell into emergency radiology because I wanted to get a little bit more operations background. And so I ended up joining an MBA program. And as part of that program, I had to work as an ER radiologist and really just enjoyed that and kept that as part of my practice as I started my career. So that's the arc of it, but fell into it, did a little bit of a wavy curve, but here we are now.
Your data and informatics background, how did that become part of your career as well?
Yeah, so that really stems from my operations background. As my career was starting was when a lot of this really new, interesting technology was coming out in the radiology field. And so a lot of my early projects were around how do we assess this? How do we implement it? Do we need it or not? And I took a lot of my operations experience and my quality experience into that, and just got really interested in the evaluation and assessment of new technology. And that really led me into the informatics piece of it.
And obviously, things like ChatGPT didn't exist when you began your radiology career, and now it's affecting your research. Needless to say, large language models have exploded into every corner of society. How did large language models in general begin to affect your own courses of study?
Yeah, and I think a lot of this is still new, so we still aren't like really steeped in large language model as general practice. And I'm an academic, but I'm more interested in like how we work on a day-to-day basis. So that's where most of my research is focused on, is like actual implementation science. And so far where we've seen large language models really have an impact in radiology is maybe around like dictation efficiency. There's a couple of platforms out there where if I say something like there is a blind ending structure in the right lower quadrant, it knows that I'm trying to say this patient has appendicitis, so it'll generate an impression around that. Things like that are really exciting because they give the radiologist a bit of time back and decrease some of our mental fatigue. And so we're exploring technologies like that. I think is really interesting on how we could potentially use it going into the future. For instance, as an emergency radiologist, oftentimes patients come to us and we don't have really any information about them at all in their order. to actually do the study. And so we spent a lot of time digging into their charts and trying to look at other resources to figure out what exactly is going on with the patient. But a large language model could surface that information relatively quickly for us. And so those are things that I'm really excited about. And I know we'll talk about this later, but patient communication is another piece of it as well.
So how can healthcare systems monitor and correct these biases when implementing new AI tools and software?
So I think that healthcare systems are still trying to figure out a lot of this out. We do a lot of testing prior to deploying any of these types of algorithms. So first we see if we actually need it, because a lot of times people are trying to deploy stuff that we don't actually need. And if we do need it, we have a small cohort that looks at it and says, hey, is it actually, if I test it, is it going to give me the information that I think it should? Is it going to be accurate information for us? Are we going to be able to use it? So we develop robust feedback mechanisms, especially between our radiologists and our IT staff. And then you have to be willing to turn it off if it doesn't work, essentially. So those are kind of the tenets that we live by when we're looking at implementing these types of systems.
Are things turned off frequently? Is there a lot of testing and trial and error and failure and things like that?
There is, and you have to be comfortable with a little bit of that. We do a lot of like background testing, so things that don't necessarily impact the patient, but we get to assess it, and we'll decide, in those phases if we just don't want to use it or not. If something goes live and we actually have it out there, and then we start to notice maybe something about it changes, because these algorithms do change, where that feedback from our radiologist is important, because we'll go back and we'll reassess it, and we will turn things off. We've probably turned off, 2 or 3 algorithms in the last year that we've gone back and said this needs to be reworked before we turn it back on again.
I have liked reading about your research on bias as it pertains to artificial intelligence in radiology. We met at RSNA. We talked about it a little bit. Can you share with our audience examples of some of the biases that exist in artificial intelligence?
Yeah, we hope that our initial assessment kind of helps with that. So when we talk about bias in artificial intelligence, a lot of times the issue is the way that the algorithm is trained. So maybe it's not trained on enough diversity of people to actually help it when a certain subgroup comes in. So from what we understand, a lot of our training models come out of California, Boston, New York. Those are very specific population types. And when you try to implement those same algorithms into a heterogeneous population type, like Connecticut has a pretty heterogeneous population, or like in the Midwest or in the Southeast, there's differences in the population that those algorithms haven't recognized. And so that's where we start to see a lot of the bias. One good example of this is breast density. So we know that Black women generally have a higher density of breast tissue than white women. We know that Asian women usually have a higher density of breast tissue than white women. But a lot of these algorithms are trained on predominantly white populations. And so if we implement a tool like that, we haven't properly assessed it in our population, which is more heterogeneous, then we have to ask, is it going to miss cancers in Black women or in Asian women? And so a lot of what we do initially is assessing the tool on our specific population.
Are you able to explain to our audience the highlight of that research?
So that's not my research specifically, but basically the highlights of it is that you have to, that an algorithm, just because it's been trained, doesn't mean that it's going to necessarily work on your population. And so whenever your healthcare system or your radiology group decides to implement something, they need to understand who their population is, what kind of background data the model was trained on, and then assess the accuracy in their own population before actually deploying that throughout their health system.
Are you working with, I'm curious, are you working with global data that can help overcome bias? Because obviously if something's trained on data from the United States, it might not be as effective when it goes global or someone takes it to try to utilize care in a different part of the world?
Yeah, I mean, I think that's a good question. And I think every research organization probably struggles with that because there's a lot of AI coming out of Asia, for instance, but none of that is trained on a US population or an African population or a European population. So a lot of the models are actually being trained in very siloed areas. And that's not just globally, that's even locally within the US. So it's hard for us to share data with institutions in California or institutions in the Southeast because of the way that our data is managed. And so there are research groups that are out there really trying to create robust data sets that pull from everywhere and that are properly labeled. So it makes doing that type of work easy. But so far, it's definitely a gap in how we do research.
Does patient privacy become an obstacle? Is it easier to get data from a different country that might not have HIPAA laws or things like that protecting patient data?
We've never really tried to source data from outside the United States, at least in our practice. In the United States, it is hard because of HIPAA laws, but also because we don't quite understand. I guess it's new. It's new these days to really think about imaging data and what it means to be HIPAA compliant in imaging data, especially as more and more people want images to build these types of algorithms. Because, for example, on an ultrasound, the information may be embedded or burned into the actual ultrasound image that we can't necessarily remove. So it's going to be hard for us to want to share that data because it does have some sort of identification on it. Even like neuroimaging with facial recognition data. So you can scan a face with MRI. Before having these models, maybe we weren't too as concerned about can you identify a patient based on facial characteristics, but now that is something that's really of concern. So we at our institution, we're very cautious about data sharing at this moment.
Absolutely. So in you bringing up patients and patient care, more patients have easy access to the results, and in some cases, before a physician is able to let them know or even follow up with what's going on in their scans. So how is this affecting how radiologists might structure the reports from here on out?
I think you're referring to the paper that you co-authored. The title of it is Increasing Patient Viewership of Complex Imaging Reports, the Paradox of the Cures Act.
Mm-hmm.
Could you just share with our audience a synopsis of that study and let them know what that was about?
Yeah, and for those who don't know, the 21st Cures Act basically said that we have to release radiology reports or really any type of information like notes about you to the electronic health record immediately after it has a final signature. And so that went into effect in April of 2021. Before that, a lot of us had been releasing notes on a time basis, maybe like 7 days later or 10 days later, just to make sure that a clinician had time to actually see those results before a patient had access to it. But now we release them immediately. So as soon as I sign a report, it shows up in your EHR record. And if you're able to access your EHR record, you can pull that report for what I said. So we were asking the questions, how many people are actually looking at their reports?
I am.
Sure, yeah.
Exactly.
I am definitely looking at my reports. And I stumbled across it. I didn't, and this was probably a couple years ago, and I was not as aware of medical studies and laws and my rights. I was just given a MyChart app, and suddenly I was getting notifications that the results of my tests had come in, and like any other shiny object on my phone, I would press it, and then I started to realize that I could see the information that my doctor hadn't discussed with me yet.
And in some cases, that could be incredibly daunting. Mm-hmm. Absolutely.
Oh, and scary. It can be scary, and then it's scary if you don't understand what they're saying, or if you see certain vocabulary words like carcinoma. It doesn't take too much thinking for a layperson to figure out that that's probably not good. And then again, the physician might not be calling you immediately to help explain what's going on.
Absolutely.
Yeah, no, and everything you say are concerns that we had when this first came out. Is how is it going to impact, the way patients feel when they read something that they haven't had time to actually have a physician tell them what that actually means. Because I think what most people don't realize is that we don't write the radiology report for the patient. We write the radiology report for the clinician. And so there's a lot of language in there that is not necessarily going to be common knowledge to the average person who's actually reading these reports. And so those were the types of questions that we were starting to ask as this 21st Century Cures Act went into effect. And so that paper that you're referencing, we really just looked at how many people are reading, and a good number of people are reading, and that trend is going up over time. And it was even going up before the Cures Act went into effect because we were sending those reports out earlier. So that was the first thing that we analyzed with that study. And we also started to ask questions around, okay, so have the radiologists actually changed the way that they dictated now that it's been out there? And, essentially the answer is no, we haven't. The way that our reports were structured before is similar to the way that they're structured now. And we started to say, well, what does that mean for patients in their ability to digest that information? And so we did a follow-up study on that as well, where we looked at actually the reading grade level of radiology reports. And usually they're at like the 11th or 12th grade level. Is recommended that when you send information out to patients as a whole, that you have them more like a 7th grade level. And so there is a differentiation there. And so we noticed that in a follow-up study. And then the question was, well, how do we actually make it so that patients can actually understand their reports? And we've done a lot of that work in our institution, where we'll highlight certain words and we'll link it into a web page that we've vetted that says, this is what this word means. This is what carcinomatosis means. This is what degenerative change means. This is what, fracture apex angulation means. We've tried to link some of that to give patients more information. But with the development of LLMs, we could probably use those to help translate a lot of that. And I know a lot of patients who copy their reports and put it into a chat GPT or something like that now, and ask them to simplify it and give them an overview of what it means. I have family members who send their reports to me and ask me to simplify it and tell it what it means.
Of course, that's what you're for.
Did you find that there was a lot of obstacles, or maybe even perhaps apprehension from the radiologist finding a way to kind of mellow down the language for the patients to access it and see those reports?
Yeah, so there's a lot of pushback, and I think understandably to ask a radiologist to change the way that they're reporting so that it's for a patient as opposed to for a clinician, because we see our reports as for the clinician, and the clinician should have that level of language to be able to speak with us accurately over time. And so it's going to be difficult to get a radiologist to dictate 2 reports basically on one patient. A lot of this is like we have high volumes now. When I'm on an ER shift, I'm reading somewhere between 90 to 150 to 200 cases within an 8-hour period, and that there's no time to actually do it twice, basically. And so we get a lot of pushback in that. And so the question is, are there alternatives to having a radiologist dictate it twice?
That brings me to my question about a correlating survey that was produced. You were a part of it. It was titled "Release of Complex Imaging Reports to Patients. Do Radiologists Trust AI to Help? What are their attitudes? What do radiologists think about AI helping them? What did you find in that study?
Yeah, so we asked respondents a level of questions, and the first question that we asked is, do they agree with the immediate release of reports or not? And about a little bit over half of people said yes, which is what we expected. Like I said before, there's a lot of consternation about these reports going out because we felt like we might get inundated with patients asking us questions because they don't understand their reports because we know that the reading grade level on them is so high. And so then we asked them, can they if we had some sort of AI that would translate the report, would you be okay with that if it was checked? And this is very specific. We said if it was checked by a radiologist before it was sent out to the patient. And a lot of people said yes. So slightly less than half, I think like 46% of people said yes, and the rest said probably not. And there's some trust factor in the AI right now. When we did this study, we were talking a lot about how AI hallucinates, how it says incorrect information. And so we have to build trust on that side. And then we asked it, okay, so if we generated those types of reports using AI without a manual check, would you be okay with that? And that dropped down to like 20% of people, I think 23% of people said yes. So I think radiologists would be okay with it if they could check it and had some control over what was still being sent out to the patients. I think we're less confident in an AI that we don't know what it's saying to the patient on the other side of that.
Sure. But even checking it involves time.
Yeah.
And radiologists' time is not something they have a lot of free time to spend doing additional work. So I can see how that the attitudes are what they are.
Through your expectations, though, through that study, did you find anything surprising?
I was honestly surprised that radiologists were okay with it, to be honest. Because usually we like to have a lot of control about what it is that is being said as it comes out of there. But I think that question around manual check really helped. So I guess it wasn't as much of a surprise as if we removed the manual check that people said no, and I was actually surprised that it didn't drop down even further than that based on the conversations I'd had.
The study notes that it's unlikely that overworked radiologists will want the additional burden of having to do a second report, like you said. And you suggested it might take legislation to even adopt that widespread use of patient-friendly reports. Do you think that that's likely to happen, or do you think that there's going to be that consistent pushback that you've been receiving?
I think as the technology improves and as people are, I guess there's two separate questions. So the leveraging of the LLMs to do this, I think over time can be more and more accepted as the technology improves, as the algorithms improve, and as there's improved radiologist trust, basically, in what that is. And there might have to be some alternate pathways around how to do that. So maybe at the end of a shift, I kind of glance through, and if anything looks odd, then I don't send it out. Or maybe we have some a mid-level provider actually checking those for us, as opposed to the radiologist checking what the LLM says versus what the report says. So that's one piece of it. The other piece of it is that usually it takes legislation for it to be commanded to do this in a layperson way. And I think the best example for this is mammography, where there is federal legislation that says, yes, you put out a radiology report, but you also send a letter to the patients that is generated in a language that they can understand. And so every time you get a mammogram, you get that letter in the mail or through your EHR. And so that's one way that this has been done in the past. And so the question is, are there other pathologies or other modalities that this needs to be expanded to over time? And I'm not sure, but I think in general, we're all thinking about how things impact patients. And so a lot of our institutions are starting to do this in some way, even without that legislation, but there's going to have to be a trust build before it's like routine care, basically, coming from a healthcare institution.
Are you working on any projects that you can talk about, or should we be looking for something to come out in the near future?
I think a lot of my stuff right now is a little bit nascent, so it'll probably be a couple of months to a year before we publish again. But the one thing that we are curious about is now that institutions have had exposure to AI over a certain period of time, does it change the way that we as radiologists have operated? Does it change the way that I dictate? Does it change the way that we teach our residents? How do we teach our residents to actually leverage these technologies in ways that we as the teachers haven't really experienced before? So some of my research is starting to lean that way going forward. And I think those are really exciting questions.
Is it too sci-fi to expect that in the future, not only will the reports be delivered simplified for a patient using AI, but do you think that possibly there will be AI characters that empathize with the patient, or do you think people will become comfortable speaking with non-humans that are delivering messaging about their health?
I don't think it's crazy to say that. I think eventually we probably will go that way in some forms. I think there was a study that came out maybe a couple of years ago where they looked at the empathy between a response from AI and empathy between a response from a primary care physician. And the AI was graded as more empathetic. And I think we could talk a lot about like why that is, or what that study curtailed, because like obviously it's not as robust to say, oh, this is what it is. But so I think that there are early indicators that people might be okay with that in the future, and it might help with some of the burden of care in some ways. So
I'm just thinking that a simplified report it's as simplified as it is, it's still saying, or could possibly say, you have cancer. But knowing that it's being read by the patient, should even a report be sensitive to the emotions of the person that's reading it?
Yeah, or should it even have that language in it? Like that's the other piece of it. Like if a simplified report, it probably, if I was creating that report, I probably wouldn't want the patient report that says you have cancer. Like that doesn't really that's going to have like some negative like mental health impacts in my opinion. But if we do it kind of the way Mamo has done it, where they put language in there that says there's something in here that we need you to follow up on, or there's something in here that we need you to contact your clinician about. So it's not necessarily saying those words that trigger negatively, but they're saying something that there's something you need to pay attention to, and so we need you to follow up, but still express that urgency.
Utilizing that language to trigger more of a response or a call of action is something that is more leaned on, as opposed to being empathetic or a little bit more softer in the delivery of something that could be pretty life-changing news delivered from your primary care physician.
Yeah.
Right. And so my preference would be to direct you in that way. You need to go see your physician and have this conversation, as opposed to some bot basically doing this.
Call this number and talk to our robot.
Right.
I think AI in all aspects of life is fascinating, and to hear your perspective on how it's affecting radiology, I appreciate it. Thank you.
Yeah, thank you for having me.
Absolutely. Is there anything else that you would like to share or go more in detail about before we let you go?
I think we covered a lot of it. Yeah.
Thank you so much for joining us for another episode of RadCentral with Dr. Melissa Davis. It was wonderful having you here and sharing your insights about the biases of AI and its implementation more into radiology.